Hello everyone. So NEET PG over. Hope you have done well. Yes, I am very much sure. Yes, now exam over, there will be mixed feeling. I know the feeling is this, which I talked to so many students. Paper was easy, sir, but we did some silly mistake. No problem. This happened with everybody. It's a competition. No worry, no worry, no worry. So yes, NEET PG over. We need to move forward. But just 2-3 days, we need to recall the questions. We try to solve those questions. Okay. So this is our purpose. So that's why I am here. NEET PG 2023 recall pediatric question. Myself, Dr. Sanjay Khatri. We try to clear so many MCQs now. Now, NEET PG 2023 rank predictor. Okay. So just enter your NEET PG score, get your rank. Roll number is optional. So yes, an academy can predict your rank because so many students, so it's a law of average. Yes, you will be there within that rank. Okay, this is not for you. You can convey to your junior or somebody watching the class for the next exam. So yes, aim next NEET PG with an academy top educator. This is the time to start your preparation. If you are targeting next year, 9th month course is there. Now the questions. Now in neonate presented with pale stool, what answer you have written in this? Conjugate hyperbilirubinemia. Liver biopsy showed bile plugs, ductal hyperplasia and fibrosis. Ductal hyperplasia and fibrosis. So what is this? Conjugate hyperbilirubinemia means it is conjugate jaundice, conjugate hyperbilirubinemia. We all know CN syndrome 1. It's unconjugated hyperbilirubinemia. So this is out. Yes, A, B, C, all three are the causes of conjugate hyperbilirubinemia. Now, how this occur? Now see, this is the liver. A simple thing. This question invariably comes in every exam, but this NEET PG, they take you one step further. Yes, this is liver, this is bile duct. When bilirubin in the liver get conjugated, this is unconjugate bilirubin. It convert into conjugate bilirubin. So conjugate bilirubin is only excrete into bile. Conjugate bilirubin excrete into bile. Suppose some problem in hepatocytes. This bilirubin not come here. Or this bile duct atresia, this conjugate bilirubin not comes here. So this conjugate bilirubin will spill into blood. This is water soluble. This conjugate bilirubin excreted by a kidney. So urine shows dark yellow color. This is the main complaint of the mother. Urine is dark yellow. Urine is dark yellow. Okay, urine is dark yellow. Okay, now if conjugate bilirubin not come into the bile duct, it will not reaches into the intestine and it will not convert into stercobilinogen. So no stercobilinogen in stool. So stool color is pale, or mother describe clay color stool. So if you are getting clay color stool and dark yellow urine, it is conjugate hyperbilirubinemia. Now these all three are the causes of conjugated hyperbilirubinemia. Dubin Johnson liver biopsy, you find black pigment. It is not given. So generally when conjugate hyperbilirubinemia, we need to differentiate whether we are dealing with neonatal hepatitis or we are dealing with biliary atresia. This is our 2DD, and answer, which is the gold standard investigation to differentiate between neonatal hepatitis and biliary atresia. It is liver biopsy. This we discussed so many times in the class. So gold standard, liver biopsy. Now see, if liver biopsy revealed bile plug, sorry, if liver biopsy revealed bile plug, ductal hyperplasia, and fibrosis, these three findings favoring extrahepatic biliary atresia. If liver biopsy shows loss of architecture of liver, there is infiltration with inflammatory cell, it shows neonatal hepatitis. So whenever child presented with conjugate hyperbilirubinemia, stool clay color, urine dark yellow, yes, we are dealing with neonatal cholestasis. Generally, we need to differentiate whether it's a neonatal hepatitis or biliary atresia by liver biopsy. Liver biopsy shows bile plug, ductal hyperplasia, fibrosis. Its favor biliary atresia. Liver biopsy shows infiltration with mononuclear cells, inflammatory cells. It suggests neonatal hepatitis. It suggests neonatal hepatitis. So am I clear? So this question, universal question. Any very time we discuss, all are the causes of conjugated, all are the causes of unconjugated. When conjugated, we tell it's either Dubie-Johnson rotor or biliary atresia or neonatal hepatitis. These are the possibilities. Now, how to differentiate neonatal hepatitis and biliary atresia? It's not HIDA scan. The gold standard is liver biopsy. This year, NEET PG question. This year, NEET PG question. Clear? Answer this question. So you may be, it take just 5 seconds to all of you to answer this question. Just 5 seconds to answer this question. Just a minute. So, impairment in vision, cherry red spots in eye, no hepatosplenomegaly. All storage disease we have discussed so many times. All storage disease have hepatosplenomegaly except Tay-Sachs, which is having no hepatosplenomegaly. And this is the key for this answer. Cherry spot also present in Niemann-Pick, but the key is no hepatosplenomegaly. Gauchers, you find massive splenomegaly. Hurler, you again find hepatosplenomegaly. Niemann-Pick, hepatosplenomegaly. Key to this question is no hepatosplenomegaly. Tay-Sachs is a storage disease. When substance not stored in spleen and liver, it is stored in brain. So Tay-Sachs classical feature is macrocephaly. Yes, macrocephaly, cherry red spot, neurodevelopmental regression, exaggerated startle response, response to noise. Baby do like this, slight noise, exaggerated startle response. So they can ask all those things, but it's an easy question. No hepatosplenomegaly, it is Tay-Sachs. Which enzyme deficiency is there in Tay-Sachs? Yes, it is due to deficiency of hexaminodase A. I hope everyone make this question right. Everyone make this question right. Answer this. This is even more easier. This is even more easier. Triad of rubella. Triad of rubella. What is the triad of rubella? Deafness. Sorry. Deafness, cataract, and CHD. CHD. Here is decreased hearing, cataract, and CHD. Which CHD? PDA or PS? In your question, PDA. We discussed torch group infection up to the level of Zika virus. and they ask such a basic question which was there in 15 year back in NEET PG. Rubella, the triad of rubella, deafness, cataract, and CHD. Sometimes I feel sorry for those who work very hard. Okay, they learn torch infection up to the edges, but examiner asks such a easy question. My friend, it's life. It's life. Okay, so you are preparing so well, but this is the easy question. When such easy questions are there, na, try to avoid negative marks. Try to avoid negative marks. In this, rubella is the answer. In this, rubella is the answer. Next question, even more easier. Yes, you feel thrill. A low birth weight neonate having periventricular calcification, sensory neural hearing loss. It is CMB. We all know in our classes, toxoplasmosis, diffuse cerebral calcification. In CMV, periventricular calcification. We are prepared to that extent. If mother is having HIV, what type of calcification is there in the neonate? Basal ganglion calcification. If mother is having Zika virus infection, what type of calcification there in neonate? It is subcortical calcification. These all four type of calcification in torch we have discussed in our class. But fortunately or unfortunately, examiner pick the easiest one. Periventricular calcification, sensorineural hearing loss is a classical seen in cytomegalovirus. Okay, so these two questions on torch, easiest question. Triad of rubella, periventricular calcification in no marks to say that all these things we have discussed in our class. Okay, yes, we are prepared. Mother is having Zika virus. What problem occur in baby? Lysencephaly, microcephaly, ocular problem, subcortical calcification. Examiner ask CMB only. No problem. Answer this. Answer. It's not answer. Just I want to give you the question. So 2 month old child present with the scalp swelling. X ratio. This is the swelling. If you see now, this is the swelling. So it is caput? No. Caput generally crosses the midline. It's intraventricular hemorrhage? No. It's not diagnosed on X-ray. It is either USG or CT scan. Swelling. It can be cephalohematoma. Yes, which is localized, not crosses the suture line. So most likely cephal hematoma and subglial hematoma, this also crosses the midline. So key, localized swelling over scalp, sharp demarcated margin. When I read this question first time, I also think it's 2 months. Yes, cephalohematoma can persist, usually resolve within 2 weeks, but can persist up to 12 weeks, means 3 months. So question very clear, localized swelling, sharp demarcated margin, not crosses the midline, seen on X-ray, it is cephalohematoma, limited by suture. Very good. See, cephalohematoma usually over parietal bones. Very good. Distinct margin does not cross the suture line. Does not cross the suture line. Distinct margins resolve over 2 to 3 weeks, but it may extend up to 12 weeks. But cephalohematoma generally resolve 48 to 72 hours. This is our class slide only. I told you difference between caput and cephalohematoma, but sometimes, this I'm telling you frankly, sometimes it's not matter whether we read it or not. Just a presence of mind, topic in our mind. It's caput? No, it's not crosses the midline. So it's localized. It's most likely cephalohematoma. That's all. That's all. Just a presence of mind will give you some 4-5 question more correct, which is the difference between getting good rank and ordinary rank. I pray, I wish all of you will select it. Answer this. Admitted, this we never discuss in our class. Management of diabetic ketoacidosis. No shame. This is the question. So, 10-year-old boy, 30 kg weight, presented with vomiting. Okay, we will see. It's loose motion, diarrhea, what? But pH 7.1, acidosis. Blood glucose 550, something alarming. Bicarb 7.3 means it is acidosis. Ketones in urine. So we are dealing with glucose high, diabetic ketoacidosis. Am I right? It is diabetic ketoacidosis. Now, biochemical criteria. How can you diagnose? It's very common. When you do the pediatrics, DNB or MD, you will get so many DK in emergency, and most of them present in the night. So hyperglycemia, when a child with altered sensorium, we just check the sugar. Sugar coming 350, 400, suspect. Then do the blood gas, VBG. pH less than 7.3, bicarb less than 18. Diabetic acidosis. Look for ketones, either beta hydroxybutyrate in blood or ketones in urine. So it is diabetic ketoacidosis. Diabetic ketoacidosis, glucose high, ketones in the urine, and blood pH less than 7.3. Yes, we can classify it mild, moderate, and severe. Very simple. pH less than 7.3, mild. Less than 7.2, moderate. Less than 7.1, severe. Bicarb less than 18, mild. Less than 10, moderate. Less than 5, severe. So now come to the question. I told you, just use presence of mind. Now, DK patient come very sick, altered sensorium, shock, but they have not mentioning shock. Okay, so sugar is high, so we need to give insulin. No issue. The key point in the management, rule of the management, fluid replacement should be begin before starting the insulin therapy. So first of all, you give 10 ml normal saline per kg in 20 to 30 minutes. If not improve, give one more bolus. Then after 1 hour, give insulin. That is 0.1 unit per kg. It's very simple. Don't look at the sugar. Don't give insulin first. First, you need to resuscitate. You need to take care of airways, oxygen, whether child need intubation, and give the fluid bolus. First, you give the fluid bolus. That will correct the acidosis. That will bring down the lactate. So our insulin will reach to the periphery. So this is the key in this question. So see, normal saline bolus. Yes, we will give normal saline bolus. Insulin within first hour. Hold on. Normal saline bolus, insulin after first hour. So B will be the right. Definitely 20 ml first hour, A and C will be not there. So somebody can argue me, you can argue with me, sir, why not 20 ml per kg insulin after first hour? Because it's not mentioning shock, it's not mentioning hypotension. Question is not saying this is the BP of the child. So we presume that child is okay hydration wise. So we give, guideline says always give first bolus 10 ml per kg. So this is the fact in DK. Why is this DK? Sugar is high, bicarbonate is low, and pH is acidic, diabetic ketoacidosis, we need to give fluid bolus. NS, give insulin after 1 hour. This is the key. If you know this key, if you have some experience working in the ward, you may get this answer. So, okay, first resuscitate the baby, give fluid bolus, give insulin after 1 hour. Insulin, if you know this question also turn out to be very easy. Then you are able to solve all the pediatric question. Because my few students make it 20 ml per kg. But yeah, it's 10 ml per kg insulin after 1 hour. Got it? Got it? Fluid replacement should begin before starting insulin therapy. So this is the key. So what you answer this? Newborn, preterm, chest retraction, diagnosed as RDS, respiratory distress syndrome. Yes, it is HMD, hyaline membrane disease. And hyaline membrane disease is due to deficiency of surfactant. Now you will be caught here. You will be caught here. So surfactant is not given here. So it is due to deficiency of which? So we go to the structure of the surfactant, which I discuss in my theory lecture when I take long 40 hours class for pediatrics, 4 classes for neonatology. This surfactant. This is the structure of surfactant. Phosphatidylcholine. This is the main component of surfactant. So 70% of surfactant is phosphatidylcholine. Phosphatidylcholine is nothing. Lecithin. Lecithin. Then remaining is phosphatidylglycerol, other phospholipid and surfactant protein A, B, C and D. It's very important. If you remember my notes now, I tell you lecithin sphingomyelin ratio should be more than 2. It indicates lungs are mature, surfactant are abundant. Why? Why lecithin? I stress this. Lecithin should be more because surfactant major 65 to 70% is lecithin only. So they are not asked it is due to deficiency of. Yes, it is due to deficiency of surfactant. The most important component of surfactant is lecithin, which constitute 65 to 70% of surfactant. That's why we always go with lecithin sphingomyelin ratio. Lecithin should be more. Lecithin should be more. That is our purpose. Lecithin should be 65 to 70%. 65 to 70%. Okay. Am I clear in this? So yes, everyone catch it. It is surfactant. It is surfactant. But what in surfactant? It is lecithin. It is lecithin. Clear na? Clear? Answer. I hold. Answer. It's a pediatric question. No, it's a physiology question. Medicine question. Surfactant. Basic principle you need to remember. This is a alveoli. This is a alveoli. Surfactant keep the alveoli open. It decrease the surface tension. Surfactant decrease surface tension and it increase lung compliance. Decrease surface tension, increase lungs compliance. This type of question very dangerous in the exam. You are not in the sound mental state. Little bit puzzled. Before that, 2 questions. Little bit. You are make it right, but little bit puzzled. Surfactant is not there. This is the language. Surfactant is not there. So what will happen? Surface tension will increase, lung compliance will decrease. Always attempt this type of question because you are sure C and D will not be there. Answer is the A and B. Relax, compose yourself. Alveoli are collapsed. in surfactant deficiency. Surfactant keep the alveoli open because it decrease the tension here. It decrease the tension here. So alveoli remain open. It decrease the surface tension. Where alveoli open, lung compliance will increase. Got my point? When surfactant is not there, surface tension increase, lung compliance decrease. Yes, gen mode. Okay, clear? Answer this. I am not sure all the choices are this because I am getting this question for one or two learners only. Not everybody post me this question. So let's see if you have some other choices, put in the chat box. We can discuss which is a correct marker for a adequate nutritional status. So anterior fontanelle closes by 6 months. This is absolutely not. Anterior fontanelle closes by 12 to 18 months. If anterior fontanelle closes early, brain growth will be altered. Microcephaly, microcephaly. Weight is 25th centile or height. Weight is 75th. Okay. Weight is 25th. Weight is 75th centile. Okay. And height is 25th centile. This is also not normal. This is also, if height is, yes, we say abnormal when it is less than 2 standard deviation. But yes, it is 25th centile is not normal. It's not an adequate nutrition status. Patient is on the lower side. Weight increase 300 gram every month. No, it is 15 gram per day. Whitmage 500 gram every month. 300 gram is not a correct choice. Height increased by 25 centimeter in first year. Birth height is 50. At 1 year, height is 75. A seems absolutely right. Height increase by 25 centimeter in first year. So see, if we put on the growth chart, this is the centile, this is 90th centile, this is 10th centile. If anything comes between 10 and 90th centile, that considered to be normal. But yeah, that considered to be normal. So we need to see if patient ideally should be at 50th centile. Ideally should be at 50th centile. But here one figure is 25th centile. So we can't use it adequate. Patient is lower than normal. It's not abnormal. When we call this abnormal, when patient is below 10th centile or above 90th centile on the growth chart. No need to remember. You will always get growth chart whether it's a pre-PG or it's a DNB exam or it's MD exam. You need to plot height, weight as corresponding to age. Got my point? So if it is less than 10 centile, it's definitely abnormal. But our word is adequate nutritional status. So 25th centile height is not indicate adequate nutritional status. If it's 50 centile, it means adequate. It's okay. Okay, it should be more than 50. But if it is 25, we can't use adequate when we have more correct option in our choice. Height increase by 25 centimeter 1 year. What I am seeing every year, one question on growth chart is there. Every year one question on L-captonuria Tay-Sachs disease is there. Every year one question on Tay-Sachs, sorry, torch group is there. Yes, we prepare for very high. Questions are not like that. We prepare for hypophosphatemic rickets, vitamin D resistant rickets, and such a easy question of rickets in the exam. See, which vitamin deficiency is? Bolak. All rickets gone. It is vitamin D deficiency, na? We are prepared with hypophosphatemic rickets, vitamin D resistant rickets, vitamin D dependent type 1, 2, all gone. They ask such a simple question. It can't be C, it can't be A, it can't be E, it's D only. Sometime, if I am going to this exam, sometime I am afraid whether such a easy question, it's okay or something. is there. Okay. See, it's a varus deformity, bow leg, varus, bow leg, valgus, knock knee, both in rickets. This bow leg is more common than knock knee. But yes, bow leg is a feature of rickets. It is due to vitamin D deficiency. I can't help now, it's your exam. Yeah, you read rickets so well. Such a easy question. We prepare up to this extent only. Wind shaped deformity, one varus, one valgus. This is also present in rickets. If examiner asks this, this goes with your standard preparation. This is not, my friend. This is not a question for you. The level which you have prepared. It's vitamin D deficiency. I can't help. I can say only sorry because you learn so hard. Not for this type of question, yeah. Not for this type of question. Answer. Answer. Somebody telling that biphasic stridor was there. So basically barking cough and noisy breathing. Stridor is there. Barking cough and noisy breathing. X-ray is like this, in which top is narrow. Top is narrow. So what is this? Stipple sign. Stipple. Church building. Church building. This is Croup only. Croup only. Acute LTB. At least so many times I am not speak this word. All the questions are from our routine classes other than DK. Diabetic ketoacidosis we never discuss in the class. Their management, no shame, na? I never discuss all questions. I am not repeat it all and again. This is from my notes. This we discuss in our test series. All are from and all are very easy. I full trust on you. If your day is wrong that day, bad day, then one or two question you will make it wrong. Rest all 15 questions you make it right. Straight go. Stipple sign. And we prepare for management of croup, nebulization with adrenaline, oral steroid. I am not going in the theory, but yes, this is the question, stipple sign. Now, this is the question. Given murmur trace suggest. So many times we discuss. S1, S2, it is systole. If murmur is here, it is diastole. So, systolic murmur. MR, systolic murmur. MS, diastolic murmur. Aortic stenosis, again systolic. Tricuspid stenosis, diastolic. So B and D is out. So if we left with A and C, now see this trace. This is S1, this is S2. Murmur start in systole, overlap the second heart sound. This is pansystolic murmur. Aortic stenosis have ejection systolic murmur. It crescendo, decrescendo type. This is not there, na. This is a pansystolic murmur. Pansystolic. And pansystolic murmur universally three causes. Whether you are in MBBS, MD or DM, pansystolic murmur three causes are there. MR, TR, PST. Simple. This is very easy question. We discussed so many times. AS question we have discussed. Even mitral stenosis, pre-systolic accentuation in the murmur we have discussed. The pansystolic murmur, MR, TR, and VST. Mid-diastolic murmur, prominent A waves in JVP. Now it's mid-diastolic. So mid-diastolic murmur present in MS and TS. MR and AS murmur is systolic. So B is out, D is out. So it's a diastolic murmur, mid-diastolic. S1, S2, S1. Murmur is here. It can be MS, it can be TS. Which other point? A wave in JVP. A, C, V, X, and Y. A wave. A wave in JVP. It is due to atrial contraction. It is due to atrial contraction. When atria contract, A waves there. So when atria forceful contract, when atria forceful contract, when there is tricuspid stenosis, then atria contract forcefully to send blood into RV. So A wave increase. Prominent A wave in JVP favoring tricuspid stenosis. Against a stenosed closed wall. Very good. Can anybody tell me giant A wave present in? Giant A wave present in? Or Canon A wave present in? Canon A waves. Anybody? Canon A wave. Complete heart block. This is not the time. You are not in the mood. I can teach you each and every wave of JVP. This is my day-night work. I am a pediatric cardiologist. I can teach you JVP like a god. It's not seen. We can feel it. Okay. So yes, but some other day we will discuss JVP. Just concentrate on A wave. Tall A wave in tricuspid stenosis. A wave absent in atrial fibrillation. Very good medicine mantra. Canon A wave present in complete heart block. Complete heart block. Complete heart block. Answer this. What you have written in this? I want answer from your side. It is pediatric question. Child is there, na? But no. Its real sense, it's a biochemistry question. Because they are asking which test, which enzyme. But why I cover this question? I need to give you the feel of clinical deficiency of thiamine is known as beriberi. Occur in alcoholic, dialysis or refeeding after starvation. Beriberi is of two types. Wet beriberi in which CVS is involved. Dry beriberi when CNS is involved. Wet beriberi, 3 points you need to remember. Peripheral vasodilatation leading to high cardiac output state. Wide pulse pressure, high cardiac output state, we always label beriberi. A for anemia, B for beriberi. Here it is beriberi. Retention of sodium and water leads to edema and biventricular failure. It is there, na? Cardiomegaly, ventricular failure. Edema, sodium and water retention. Pleural effusion, ventricular failure. So all features occur due to which deficiency? Thiamine deficiency. It's a wet beriberi. And to diagnose this, we need to know RBC, transketolase level. Transketolase level. Some other day we will discuss dry beriberi, Wernicke's encephalopathy, Korsakoff psychosis, retrograde amnesia. We will discuss, but this is not the time. Thinning of hair, I don't know, but जैसे ही आया raw egg consumption, only one thing came in our mind. It's biotin. Evident. Raw egg ingestion leads to which vitamin deficiency? Biotin. It's not occur so easily. A person need to consume at least 5 egg daily for 3 to 6 months. Then only biotin deficiency will occur. But yeah, raw egg biotin deficiency. We are learning this thing from last 15, 25 years when I was in my MBBS. Question come in NEET PG. This NEET PG questions, vitamins everywhere. They choose this year. Now, diarrhea, dermatitis, dementia. I am fed up of this question here. Every NEET PG, this question was there. Image base, necklace, whatever this. This is niacin deficiency. You people are not reading for to do this type of question, yeah. But this is exam. This is life. Okay. So urine turn black on standing. 100% will do it right. It is L-captonuria. Last year they asked, last NEET PG, L-captonuria is due to deficiency of homogentisic acid oxidase. This year they ask, even simpler, urine turn black on standing. It is L-captonuria. What we can do? Such a easy questions. Now, a patient present with bleeding gum and decreased wound healing. All these is related to scurvy, vitamin C deficiency, and vitamin C we needed for collagen synthesis. This is also because I am not getting all other choices, but it is straightforward again. I am not telling this is a pediatric question, but a child present with bleeding gum and decreased wound healing. Scurvy, and we remember all the x-ray of scurvy: Wimberger sign, Frankel line, Pulkin spur, scurvy line, periosteal bleed. All these things we learn in scurvy. Last NEET PG they given x-ray of scurvy. This NEET PG they are asking what happened in scurvy. It is delayed collagen synthesis which lead all these things, Sweat chloride test measured in which disease? I told you, na, every exam they have a question on cystic fibrosis. Is this question was there? Only 3 or 4 students given me this. I don't think that this was there. They asked so easy question from cystic fibrosis. Yes, sweat chloride test. If chloride more than 60, test considered to be positive. If chloride less than 30, test considered to be negative. If it's between 30 to 60, it is equivocal. You need other test to diagnose, to confirm your diagnosis. Okay, such a easy, na? So cystic fibrosis, sweat chloride test measurement. If they can ask what's value, what other test, what mutation, we can understand. But such a simple test, sweat chloride test used in the cystic fibrosis. Yes, cystic fibrosis mutation they can ask, which is the commonest mutation. FA508 is the commonest mutation. Action potential difference they can ask. We read up to that extent. Every year they asking something about cystic fibrosis. Previous year question was controversial about cystic fibrosis. This year, no controversy. Sweat chloride test used in the measurement of cystic fibrosis. Some question on zinc deficiency leads to acrodermatitis. Gauchers, they ask enzyme deficiency, glucocerebrosidase. Wilson disease, which level you need to know? Serum ceruloplasmin level. Then 2-3 questions from AML. I considered those I can discuss, but those are typically pathology question. Yes, question on glomerulonephritis, post-streptococcal, membranoproliferative, dome and spike pattern, the classical history, but basic they ask the pathological finding. So overall, my expression of this paper, we cover so many questions in pediatrics. Yes, question from PM, question from cystic fibrosis, question from vitamin, torch, basic cardiology questions, but they are very easy. Only one typical question, it's not typical, which we have not read in day-to-day practice, diabetic ketoacidosis. Rest all are very simple question. Okay, that's the life. What next? What next? So, NEET PG 2023 over. So this time you have a feeling paper was very easy. Yes, we expect cutoff will go high because I made some silly mistakes. It's not you. Everybody make that silly mistake. Okay, now you have to decide two things. It's my sincere advice. What next? If you feel you have put your best effort and you are okay with your results, wait for results. Don't bother about rank. It's your destiny. If you want to take ortho, your few questions get wrong on that particular day, no problem. Compromise with surgery or ENT. Your destiny want this thing. Suppose you are waiting for radiology, but few questions get wrong, but you are happy. You have done your best effort. You get derma. Carry on with derma. No need to repeat. Happy. Something God is given. Something God wants that you take this branch. That's why these two, three questions you make a silly mistake. But you feel that was not your best effort. You have few subjects left, some problem in 15-20 days, in last 3 months, some family problem, some unavoidable reasons, you can't put your best effort. My friend, this is not the end of the life. INI-CET is waiting for you. So relax for at least a week. Spend time with your family, mother, father, friend, whatever, with family, and relax. Start again. Nothing to lose. Nothing to lose. It's a failure. No problem. Accept your failure. But if you feel that you have given your best, don't compromise your rank. मुझे तो वही सब्जेक्ट वही रैंक चाहिए वही कॉलेज चाहिए. No, destiny. Okay, take this thing, do better in that thing. But if you this was not your best effort, relax and start again. Trust on God. He has think something for you, my friend. So keep reading. It's life. Keep reading. Let's crack it. I wish all of you get your dream branch, your dream college. But whatever you learn, whatever you read, at least you get something on that proportion. If you don't put your best effort, keep reading, keep reading. Don't be disheartened. Don't be disheartened. This is not the end of the life, my friend. If you go to the history of everybody, na, they have multiple failure in their life. You have this failure. Accept this and move on. So keep reading. Let's crack it. Thank you. Bye bye. Best wishes for your results or whatever your future. Myself, Dr. Sanjay Khatri. Thank you.